Millions of people believe things about abortion that doctors say are completely false, and some of those myths are quietly causing real harm. What if everything you were taught was only half the story? Today, we separate dangerous fiction from medical fact. What you're about to learn might genuinely surprise you. Let's get one thing absolutely clear before we dive in. This video is not political. It is not here to tell you what to believe, what to value, or what decisions to make. This is a health education video, full stop. The same way we talk about heart disease, diabetes, or cancer, we are going to talk about abortion with facts, with science, with compassion. Because here is the uncomfortable truth. Abortion is one of the most talked about topics on the planet, and simultaneously one of the most medically misunderstood. Think about that for a second. Millions of people are forming opinions, making healthcare decisions, writing laws, and having arguments based on information that is either incomplete, exaggerated, or outright false. And that has real consequences for real people, for real bodies. Here are three numbers I want you to hold in your mind right now. According to the Guttmacher Institute, approximately 1 in 4 women in the United States will have an abortion by the age of 45. In the United Kingdom, over 200,000 abortions are recorded every single year. In Australia and Canada, the rates are similarly consistent across all demographics, cutting across age, income, religion, and relationship status. This is not a rare event happening to a specific type of person. This is a common medical experience, and yet the conversation around it remains buried under layers of stigma, shame, and misinformation. So today, we are changing that. We are going to walk through 5 major myth categories: safety, mental health, fetal development, medical necessity, and access. And we are going to replace myth with medicine, fear with facts, and confusion with clarity. Stay with me. Because some of what you are about to hear will genuinely challenge what you thought you knew. Before we can bust any myths, we need to start with the foundation. What is abortion, medically speaking? The clinical definition is this: abortion is the termination of a pregnancy before the fetus is capable of surviving outside the uterus. That is it, that is the medical definition. Now, here is something that surprises a lot of people. There are actually 2 categories of abortion in medicine. The first is an induced abortion, a deliberate procedure chosen by the patient. The second is a spontaneous abortion, which is the clinical term for what most people call a miscarriage. Yes, miscarriage and abortion are the same word in medicine. If you have ever had a miscarriage or know someone who has, you may have seen that term on a medical chart and felt confused or even distressed. That reaction is completely understandable. But medically, both involve the ending of a pregnancy. The difference is whether it was intentional or natural. Now, when people talk about abortion in public discourse, they are almost always referring to induced abortion, so let's focus there. There are 2 main types. The first is medication abortion, sometimes called the abortion pill. This uses a combination of 2 medications, mifepristone and misoprostol. Mifepristone works by blocking a hormone called progesterone, which is essential for the pregnancy to continue. Misoprostol, taken 24 to 48 hours later, causes the uterus to contract and expel the pregnancy, a process that resembles a heavy, crampy period or an early miscarriage. This method is typically used up to 10 to 12 weeks of pregnancy, though the window varies by country and clinical guidelines. The second type is a procedural abortion, sometimes called surgical abortion, though that term can feel misleading because many procedures don't involve a traditional surgical incision. In early pregnancy, this often involves manual vacuum aspiration, a gentle suction procedure that takes just a few minutes. In the second trimester, a procedure called dilation and evacuation, or D&E, is used. These are performed by trained clinicians in regulated healthcare settings. Here is a fact that surprises many people. Over 90% of all abortions in the United States and the United Kingdom happen in the first trimester, that is, within the first 12 weeks of pregnancy. The vast majority happen even earlier than that. Why does this matter? Because a lot of the most extreme imagery and rhetoric in this debate centers around late-stage procedures that represent a tiny fraction of abortion care. We'll come back to that. Now, let's get into the myths. And I want to start with the one that is most likely to affect your health decisions directly. Right now, the most Googled question about abortion is this: is abortion dangerous? Let's answer it properly because the answer is not what most people expect. Myth 1: abortion is extremely dangerous and life-threatening. This is one of the most persistent myths in reproductive health, and it is also one of the most medically inaccurate. The World Health Organization states clearly that legal, safe abortion is one of the safest medical procedures that exists. The risk of death from illegal abortion is less than 1 in 100,000 procedures. To put that in perspective, the risk of dying from a penicillin injection due to allergic reaction is higher than the risk of dying from a first trimester abortion. Now, here is the statistic that stops most people in their tracks. According to CDC maternal mortality data, the risk of dying from continuing a pregnancy to full term and giving birth in the United States is approximately 14 times higher than the risk of dying from a legal abortion. Read that again: 14 times higher. That does not mean pregnancy is dangerous for most people. It means that when we compare the two in clinical terms, abortion is actually the statistically safer medical event for the pregnant person. Of course, safety is not uniform. It depends heavily on how legal, accessible, and well-regulated abortion care is. In places where abortion is restricted or criminalized, complications and deaths rise not because the procedure itself is dangerous, but because people are forced to seek unsafe alternatives. That is where the danger comes from. Myth 2: abortion causes heavy complications and leads to infertility. According to both the American College of Obstetricians and Gynecologists and the Royal College of Obstetricians and Gynecologists in the UK, serious complications occur in fewer than 1% of first trimester abortions. That is a lower complication rate than most dental procedures. And infertility? The evidence is equally clear. There is no credible medical evidence that a safe, legal abortion causes future infertility. After a first trimester abortion, fertility typically returns within 2 to 4 weeks. In fact, it is possible to become pregnant again before your next period even arrives, something clinicians actively counsel patients about. Risks like infection or uterine perforation do exist, but they are statistically rare when care is provided by licensed, trained professionals in a regulated setting. The takeaway here is simple. If you have ever been told that having an abortion means you might never have children, that claim is not supported by medical science. Myth 3: the abortion pill and the morning after pill are the same thing. This one is not just a myth, it is a medically dangerous confusion. These are two completely different medications with completely different mechanisms of action. The morning after pill, brands like Plan B, contains levonorgestrel. It works by delaying or preventing ovulation. It does not end an existing pregnancy. It prevents one from beginning. It must be taken within 72 hours of unprotected sex, and it has no effect once a fertilized egg has already implanted. The abortion pill, mifepristone and misoprostol, ends an established pregnancy by blocking progesterone and triggering uterine contractions. It is a prescription medication used under clinical supervision. Confusing these two medications has led to real harm, people taking the wrong medication at the wrong time, expecting effects that will never come. If you take nothing else from this section, let it be this: they are not the same, not even close. Now I need to ask you something. You have probably heard that abortion causes serious, lasting psychological damage, trauma, depression, that women never recover. But what if the science tells a completely different story? Stay with me. This might be the section that surprises you most. Because the narrative around abortion and mental health has been told loudly, emotionally, and repeatedly, from pulpits, in legislation, across social media. But what does the actual research say? Myth 4: abortion always causes severe depression, trauma, and PTSD. The largest and most rigorous study ever conducted on this topic is called the Turnaway Study, led by researchers at the University of California, San Francisco. Over 5 years, they followed hundreds of women, some who received abortions and some who were denied abortions and had to continue their pregnancies. The findings were striking. The most commonly reported emotion among women who received an abortion was not grief. It was not trauma, it was relief. That was the dominant emotional response, reported by the majority of participants, and it remained stable over the 5-year follow-up period. Meanwhile, women who were denied access to abortion showed significantly higher rates of anxiety, lower self-esteem, and reduced life satisfaction compared to those who received care. Now, does this mean everyone feels relieved? Absolutely not. Reproductive health decisions sit at the intersection of personal values, relationships, finances, faith, and life circumstances. Some people do experience sadness, grief, ambivalence, or complicated emotions, and every single one of those responses is valid and deserves compassionate support. No one should be dismissed, but the clinical point is this: emotional difficulty after abortion is not inevitable, universal, or uniquely caused by the procedure itself. Pre-existing mental health conditions, lack of social support, stigma, and coercion are far stronger predictors of poor mental health outcomes than the abortion itself. Myth 5: post-abortion syndrome is a recognized medical condition. Let's be precise here. Post-abortion syndrome is not recognized by the American Psychological Association. It is not recognized by the Royal College of Psychiatrists. It does not appear in the DSM-5, the diagnostic manual used by every mental health professional in the English-speaking world. It does not appear in the ICD-11, the international classification used by the WHO. It is not a diagnosis, it is not a syndrome. It does not have a clinical definition, diagnostic criteria, or evidence base. That does not mean emotional distress after abortion doesn't exist. It can, and it does for some people. But calling it a unique syndrome caused specifically by abortion is not supported by medical science. The expert recommendation from every major psychological body is clear. Offer counseling and support before and after, not because of a syndrome, but because reproductive health decisions are significant life experiences that deserve compassionate care. The next section, it is going to get into the biology. And there is one particular claim about pain, about consciousness, about what a fetus actually experiences, that the science addresses in ways most people have never been taught. Myth 6, fetuses feel pain during first trimester abortions. This claim is emotionally powerful. And it is used frequently in public debate, but let's look at the neuroscience because the biology here is actually quite specific. Pain is not simply a physical stimulus. It requires a conscious experience, and conscious experience requires a brain structure called the thalamocortical connection. This is the neural pathway that connects the thalamus to the cortex and allows for the perception of pain as a felt, conscious sensation. According to a landmark review published in JAMA and confirmed by the Royal College of Obstetricians and Gynecologists, these connections do not develop until approximately 24 to 28 weeks of gestation. Before that point, the neurological architecture required for conscious pain perception simply does not exist. Remember, over 90% of abortions happen before 12 weeks. The structures necessary for pain awareness are not even beginning to form at that stage. The scientific consensus, as stated by JAMA, ACOG, and the RCOG, is that fetuses cannot consciously feel pain during first trimester procedures. Myth 7, it is a scientific fact that life begins at fertilization. This one requires careful, honest unpacking because it blends science with philosophy in a way that misleads people on both sides of the conversation. Here is what science actually describes: fertilization, implantation, cell division, embryonic development, organ formation, viability. These are biological processes. Science documents them in extraordinary detail, but here is what science does not determine: the moral, ethical, or legal status of those biological processes. That is not a scientific question. That is a philosophical, theological, and societal one, and it is one that thoughtful, intelligent, well-meaning people have answered differently for centuries. When someone says science proves life begins at fertilization, they are taking a biological fact that a genetically distinct entity forms at fertilization and attaching a philosophical conclusion that science itself does not make. Understanding this distinction is not a political statement, it is intellectual honesty. Myth 8, later abortions are common elective procedures chosen for convenience. Second trimester abortions account for approximately 7 to 9% of all abortions. They are not common, and they are almost never elective in the way that word implies. The most frequent reasons for second trimester abortions include fetal anomalies detected through prenatal screening, conditions incompatible with life like anencephaly, maternal health emergencies that arise mid-pregnancy, and delayed access caused by financial barriers, lack of local providers, or difficulty navigating the healthcare system. Understanding why later abortions happen fundamentally changes how we understand the people who have them. These are rarely casual decisions, they are often devastating ones. Here is something that is not debated in obstetrics wards, not controversial among OB-GYNs, not questioned by maternal fetal medicine specialists. And yet it is almost never part of the public conversation. Myth 9, abortion is never medically necessary. Let's go through the clinical situations where this becomes life or death. Ectopic pregnancy. This occurs when a fertilized egg implants outside the uterus, most commonly in the fallopian tube. The tube cannot support a developing pregnancy, it will rupture, and when it does, it causes internal hemorrhage that can kill within hours. The treatment, the only treatment, is termination. Every major medical body in the world considers this a medical emergency requiring immediate intervention. Severe preeclampsia and HELLP syndrome. These are pregnancy complications involving dangerously elevated blood pressure, organ failure, and blood clotting disorders. In severe cases, the only way to stop the progression is to end the pregnancy, sometimes at a gestational age where survival outside the womb is not possible. Septic miscarriage. When an incomplete miscarriage becomes infected, the management often involves exactly the same clinical procedure as an induced abortion, removing the remaining pregnancy tissue. Denying this care because it resembles abortion has led to preventable deaths in countries with strict abortion bans. This is not hypothetical. It has happened. Fetal diagnosis incompatible with life. Conditions like anencephaly, where the fetal brain does not develop, mean the pregnancy cannot result in a surviving child. For many families, continuing the pregnancy means weeks or months of anticipatory grief, physical risk, and emotional devastation for an outcome that was never viable. The American College of Obstetricians and Gynecologists, the Royal College of Obstetricians and Gynecologists, and every major obstetric body worldwide agrees there are clinical situations where abortion is not a choice, it is a medical necessity. Denying that is not a moral position, it is a factual error. Now, even with all of this information, millions of people across the USA, UK, Canada, Australia, and Europe still cannot easily access abortion care, and the health consequences of that gap are significant. Let's talk about what the evidence shows. Myth 10: restricting abortion reduces the number of abortions. This is perhaps the most policy-relevant myth of all, and the data on it is remarkably consistent. The World Health Organization analyzed abortion rates across countries with different levels of legal restriction. The conclusion: abortion rates are nearly the same in countries where it is legal and where it is restricted. What changes is not how often it happens. What changes is how safely it happens. In countries with legal, accessible abortion care, procedures are performed by trained clinicians in hygienic settings with appropriate follow-up. In countries where it is restricted, people seek clandestine procedures, often self-administered, often in unsafe conditions, with dramatically higher rates of complications and death. The WHO estimates that approximately 45% of all abortions globally are unsafe, nearly all of them in countries with restrictive laws. Unsafe abortions cause around 7% of all maternal deaths worldwide. That is not a political statistic, that is a public health catastrophe. Practical health advice for viewers. Regardless of where you live or what your beliefs are, if you or someone you know is facing an unintended pregnancy, the most important step is to seek information from a licensed, accredited healthcare provider as early as possible. Earlier access means more options, greater safety, and better medical outcomes. Organizations like Planned Parenthood in the USA, BPAS in the UK, MSI Reproductive Choices in Australia, and Options for Sexual Health in Canada offer confidential, non-judgmental support. Let's bring this home with what the medical community actually recommends, regardless of your personal circumstances. Number 1, know your options early. If you are pregnant and unsure about continuing, seek medical consultation as soon as possible. Time matters clinically, both for safety and for the range of options available to you. Number 2, verify your information sources. Not all pregnancy resource centers are medical facilities. In many countries, crisis pregnancy centers are not regulated healthcare providers and are not required to provide medically accurate information. Always verify that you are speaking with a licensed clinician. Number 3, mental health support is not weakness, it is healthcare. Whether you continue a pregnancy, have an abortion, experience a miscarriage, or place a child for adoption, reproductive experiences can be emotionally complex. Counseling, peer support groups, and mental health professionals can all be part of healthy recovery. Number 4, contraception conversations. The most effective way to prevent unintended pregnancy is consistent, correct use of evidence-based contraception. Speak with your healthcare provider about the method that best fits your health, lifestyle, and reproductive goals. Number 5, stigma is a health issue. Research consistently shows that shame and stigma prevent people from seeking timely care. The longer someone waits, often because of fear of judgment, the more limited and complex their options become. Reducing stigma is not just a social good, it is a public health intervention. We have covered a lot of ground today. Let me leave you with the 5 things I most want you to remember. 1. Legal abortion is one of the safest medical procedures that exists. Complications are rare, infertility is not a documented outcome, the risk profile is lower than most people assume. 2. The most commonly reported emotion after abortion is relief, not trauma. Mental health outcomes are shaped by many factors, and post-abortion syndrome is not a recognized medical condition. 3. The neuroscience of fetal pain is clear. The structures required for conscious pain perception do not exist in the first trimester when the vast majority of abortions occur. 4. There are clinical situations, ectopic pregnancy, septic miscarriage, severe preeclampsia, fatal fetal diagnoses, where terminating a pregnancy is not a moral debate, it is emergency medicine. 5. Restricting abortion does not reduce abortion. It reduces safe abortion, and that costs lives. You deserve access to accurate medical information. You deserve to make decisions about your own body and your own health based on evidence, not fear. Whether this video confirmed what you already knew, challenged something you believed, or gave you language to explain something you could never quite articulate, I hope it helped. Take care of yourselves. And as always, your health matters.